Thanks, Paul, and thanks for the opportunity to be here. As an orthopedic surgeon, I represent the specialist view on this panel, and I've had the opportunity over the last 12 years in a variety of different leadership roles for the American Academy of Orthopedic Surgeons to work with Bill Kramer and PBGH and Paul Ginsberg and Pat Conway when he was at CMMI and others. I'd like to think that that's because as orthopedic surgeons, we're highly intelligent and uniquely qualified to address some of the challenges, but I have a feeling it has more to do with the fact that we do a lot of really expensive procedures and people are having trouble getting their arms around how do we control both the cost and the volume of those procedures. And so it's been interesting for me, having lived in this space for a while, that we've kind of focused on this shift from fee-for-service to capitation, and really we know that in fee-for-service we incentivize overutilization. And in the primary care world, as we've shifted to capitation, we've addressed some of those perverse incentives, but we still continue to pay specialists through fee-for-service predominantly, and whether that's through a bundle payment or just a traditional fee-for-service mechanism. And so I've had the opportunity to be involved in the development of a variety of different bundle payment programs. We started our first bundle payment when I was at UCSF through the Integrated Healthcare Association in 2008, and we got a grant from AHRQ. It was a 3-year grant to launch a bundle payment for hip and knee replacement. At the end of 3 years and $750,000 of AHRQ's money, we enrolled exactly one patient after 3 years in that bundle. We published our experience in Health Affairs, and we learned a lot from that, and that informed some of the dialogue around the BPCI program. And when the BPCI program was launched, 80% of the hospitals that participated in BPCI had orthopedics in there amongst the DRGs that were included. We were one of the pioneer BPCI programs in 2011 in Model 4 and learned a lot of lessons from that, and then shifted to Model 2. We then became the first mandatory bundle payment under the Medicare program through the CJR program in 2016. And so we have about a decade worth of experience now around bundle payments for procedures. And essentially what we've learned from that is that the payment model and changes in the payment model drive changes in the delivery model, right? And so that prior to the introduction of bundle payments, as an orthopedic surgeon, I would do my procedures in a facility. My patients would get a variety of different post-acute care in a variety of different places. I never communicated with those people. They never communicated back to me. And by incentivizing us across that care continuum, we were forced to start communicating with each other and understand where the value was added to patients. We eliminated a lot of non-value added post-acute care. And essentially, to summarize, after a decade, we reduced the length of stay somewhat for these procedures. We reduced the utilization of post-acute care. And so overall costs decreased slightly with no detrimental impact on outcomes, which as a physician was not very inspirational to me. I didn't understand how that was helping me improve the health of my patients or improve the value of care that we deliver to our patients. And so I could sum up my experience with the Medicare bundle payment program in total joint replacement by a patient who I saw last month. It was a 68-year-old woman who I saw who had a bundle payment, had a knee replacement done through the BPCI program, a Medicare bundle payment, 18 months prior, and had a perfect bundle by the Medicare definition. She was in the hospital for one night, was discharged directly home with no post-acute care, was not readmitted to the hospital, and had no complications within 90 days. Came to see me 18 months later and was absolutely miserable. So does anybody want to guess why? So knee replacement wasn't the right procedure for that patient. It wasn't the right treatment for that patient. So when we bundle at the procedure level, we get exactly what the system motivates us to do, which is we get more procedures whether or not those procedures are appropriate or not. After 18 months, no one had ever measured that patient's pain, functional status, quality of life, or mental health. No one had ever done that until she presented to our practice. And every single patient that we see with joint pain, the first thing we do is use validated measures of pain, functional status, quality of life, and mental health to determine what's the most appropriate treatment for that patient. That patient had a knee replacement for untreated anxiety and depression, unfortunately. A knee replacement, as effective as it is not a good treatment for anxiety and depression. And so what we've learned from this is we need to move upstream from bundling at the procedure level to bundling at the condition level, which is what we're now doing in Austin. We have a bundle payment for the management of hip and knee arthritis. So what does that do? Just as the bundle payment at the procedure level incentivizes us to change our behavior and coordinate care between acute and post-acute providers, Now we have been forced to coordinate care across the spectrum of people who manage arthritis. What does that mean? We have mental health providers on our team. About a third of the patients that we see for hip and knee pain screen positive for anxiety and depression. That needs to be managed and treated way before we even think about that patient undergoing a major surgical procedure that could have significant implications for their quality of life. So we have behavioral health trained social workers on our team. We have a nutritionist. Many of our patients have lifestyle issues that need to be addressed before we would ever think about any type of surgical procedure. We have physical therapists, chiropractor, acupuncture, and advanced practice nurses. The least important person on that team in terms of the person who interacts the least with those patients is an orthopedic surgeon, right? So I've never understood why somebody wakes up with knee pain, they go to see an orthopedic surgeon, right? So if I wake up with a headache, I don't go see a neurosurgeon, right? But if I have knee pain or shoulder pain, I would think nothing about my primary care doctor referring me to an orthopedic surgeon. It makes no sense to me. And so I am the least important person on that team, and yes, about 10 to 15% of those patients are appropriate to see an orthopedic surgeon, but 85% are not. And so what have we learned over 18 months with this bundle? We've significantly reduced the per capita cost for managing those patients, and not just by ordering fewer MRI scans and injections and doing things that don't work. We've reduced the number of surgeries by 25% across the population that we treated, but we've added cognitive behavioral therapy. We've added nutritional services and other services for those patients that improve their overall health. And most importantly, we're measuring the things that matter to those patients, which is pain, functional status, quality of life, and their overall mental health. And so what have we learned from this experience? We've learned, again, that the payment model, changes in the payment model drive changes in the delivery system, that bundle payments incentivize greater coordination and communication across providers, but bundling at the procedure level limits value creation by ignoring the concept of appropriateness, that bundling at the condition level drives value by incentivizing greater coordination and communication across all of the providers that manage people with chronic pain, which is not just orthopedic surgeons in my case. It forces us to measure outcomes that matter to patients and to use those outcomes in true shared decision-making conversations with patients. So again, I appreciate the opportunity to be here, and I look forward to the discussion.
Thank you, Kevin. Just one question. You have any thoughts about what the trajectory might be to getting these ideas about condition-specific bundle payments more widely used?
Well, what we've learned, and to Mai's comments, that this is something if it's challenging for a payer to bundle at the procedure level, it's even more challenging to bundle at the condition level. So there's a lot of structural problems that we've had to work through in our market. We're doing this on a pilot with, we first started with our county health district, and that's been a very successful pilot. We now have it with 2 employers and 1 regional payer in our market. And there's a lot of changes that need to be made to claims adjudication. And also benefit design matters a lot, right? So if I have a patient that's treated in this model and decides, well, the doctor down the street I know operates on everybody that walks through the door, that's where I'm going to go to get my care, it's going to blow up the model. Fortunately, our experience so far has been that once patients are treated in this model and they understand all of the incentive, all of the different services that they can access, telehealth, access to cognitive behavioral therapy, nutrition, physical therapy, other things, to our knowledge, we haven't had a single patient that's left the model yet, but the benefit design and steerage matters in that type of model.
Thank you.